I'd like to welcome Keetha Hanlin, who's a specialist in our field in venous diagnosis and treatment. I'm going to allow her to introduce herself for many of you who may not be familiar with her decades of work in our field.
Thank you, Dr. Hingarani. I greatly appreciate the opportunity in coming on today and joining this podcast. I think an excellent way to get the education out there in regards to sclerotherapy. My role with Methafarm, specifically with asclera, is one of the senior clinical advisors. So for me, education is extremely important. It's what I develop out and provide to the U.S. market for sclerotherapy utilizing asclera. So I am with a lot of practitioners all across the country. I'm in their practices. Sometimes I'm training them hands-on and or providing consultative services, whether it's with sclerotherapy and or the business of sclerotherapy, adding it into their practice. So, for our division with Asclera, I would say about 60% of what we are dealing with are med spas, dermatology, and then the latter part of that percentage, that make up that 100, is vein clinic. So I'm thrilled that I get to work with Asclera. I've been utilizing polidocanol for quite some time. I've been injecting since 2002 when I opened up a medical spa of my own. So I've got a lot of experience injecting. I started off with hypertonic saline back in the day and then progressed to polydolcanol. And then I could not have been more excited when Asclera became FDA approved here in the US market and have been utilizing it ever since.
Talk a little bit about the education in a field with sclerotherapy, because I find that a lot of practitioners during their formal education don't really get much education on sclerotherapy. It's a fundamental technique, it's a fundamental skill. Can you talk a little bit about education in this field? Because it's something that I feel gets the short end of the stick.
Yeah, absolutely. And it is interesting because I've worked with so many vascular surgeons over the past, 30 years. And I remember when I first got asked to help somebody with sclerotherapy. I've been in peripheral intervention and you working with various different modalities for venous insufficiency. So I've worked alongside a lot of the vascular surgeons as well as interventional radiologists, interventional cardiologists, people that, you would think would have received the training with sclerotherapy, but when they've come to me and said, "Oh, hey, you know how to do sclerotherapy?" And I'm like, "Oh, you don't?" And they're, "No, we were never trained that in our fellowship." And I thought, wow, okay, how are we supposed to treat some of that superficial, issue where patients come back, and even though you treat that underlying disease, you still have some remaining visible, telangiectasias and or reticulars. You've got to have, you know kind of that full spectrum of treatment of care provided for your patients, and that's something that I talk to practitioners all across the country. You've got to have that start to finish when it comes to a vein patient. You kind of need to offer it all. And even though, try to get somebody, I know a lot of the physicians out there find sclerotherapy a very tedious, cumbersome task. You're dealing with a lot of very tiny little veins. And so most of the practices that I'm in, the the nurses are providing this service. But yeah, the training for the fellows is what I have found over the years is just not there yet. So, and hands on, as you well know, hands on training is crucial. We know the didactic part, right? We know the anatomy and physiology part of it, but the actual hands-on of this it's technique, and you stated that it's a technical, procedure that takes a lot of practice. This isn't just sticking a GSV or sticking an SSV and putting a catheter or a wire in it. Like, these are tiny little vessels that are 1 millimeter and under. So, yeah.
I want to get a little bit into the nuts and bolts. How do you, when you have a patient who's a candidate for sclerotherapy, how do you actually get this job started? All the way from the patients to the procedures, the equipment, everything.
I love this question. Thank you. Something that we're really trying to create a mindset of is that algorithm and treatment of care for just any patient that comes in to any of like the med spa, the derm practice, your vein cleanse, anybody. How do we handle that patient that comes in that says, I don't like these veins on my legs? So, I still have the med spas and the derm practice. I still have them ask those questions, those hasty questions. And because they don't treat, the underlying disease, I want to make sure that they have a very strong awareness of, okay, I have this patient, and if I ask them all of these questions, the history and physical is there. What do I do with them? And so I educate them in stating you've got to have a referring physician that you can refer to for a duplex ultrasound. So find that person so that they can have that duplex. I don't like anybody treating a patient with sclerotherapy until they know for certain there is no underlying disease. Because as you well know, if there's anything underlying, a patient is wasting their time and their money when they're just coming in for the cosmetic portion. And that's going to create a lot of very frustrated patients. And then sclerotherapy gets a bad name. And then people aren't getting sclerotherapy. What they're doing is that they're going and finding laser modalities like transdermal cosmetic laser modalities to take care of their issue. And I mean, the gold standard is sclerotherapy. And I always tell my practitioners, if you can get a needle into it, you need to inject it. And whatever else is remaining, utilize, your laser, your 1064 ND YAG. That's a great way to approach those types of patients. So starting with that ultrasound, figuring out, is this a medical patient or is this a cosmetic patient? And then there's two different routes that that patient can go into, and that will be how you'll move forward with your practice, whether you're somebody that does treat underlying disease or you're somebody that doesn't treat underlying disease. And I'll flip around to the people that are currently treating the underlying disease. Try to connect with somebody. Like, if you don't want to do the sclerotherapy, try to connect with a med spa and or a derm that does perform that sclerotherapy. And it's a great symbiotic relationship. My med spa had one side of it that had a vascular surgeon, and the other side was my med spa. And we were across the hall from each other. And so if I ever had a patient that, presented with any of the hasty symptoms, I would send them right across the hall, make an appointment, get your ultrasound done. Most of those patients would come back to me for the cosmetic sclerotherapy, and they might have even come to me for other cosmetic procedures, but we did such a great job at taking care of these patients. It was that full, the gestalt of care for them. I hope that answered your question fully. If I missed something, please ask.
It did. But what about some of the logistics? Getting your practice started, technique, um, um,
Yep.
getting the equipment. There's still a lot more besides getting the patient. There's
Correct.
also in
Correct.
terms of actually doing the
Yep.
procedures.
So if you wanted to start doing it, training is key. Myself and then one of the other senior clinical advisors, we have done several live webinars in the past. Those are great resources. So we provide didactic unfortunately, we don't provide the hands-on. So there are training centers across the country. Empire, I know, is one. We've got a couple in Florida, just in various locations throughout the country. You can always reach out to our customer service, and most times I can find some really great programs off of the list that I have, fleshed out for people to attend that I find, you know, are great with the hands-on portion. But we can provide the didactic portion. That's crucial. I show up in places where people need help and they've got the didactic down, but they still struggle with the hands-on. So finding a training program where you can get the hands-on is key, I believe. And then as far as getting all the supplies, we do have a list of supplies for our practitioners. So if anyone needs that list, we have that. I can send that off to anybody. And it's a very, very simple list of supplies. Most of those supplies, most everyone probably already has in their practice, with the exception of the asclera, if they already don't have it in their practice. But that's very simple to order as well. Our customer service department is great. And then we've got, various different representatives across the country as well.
And also, besides the sclera, what size needles do you need? And I find that different practitioners like certain types of needles compared to others. I have my preferences, obviously. Um, where do you start? And also headlights or some type of magnification to help some of our older eyes, so to speak.
Oh my gosh, I have those. I literally I was thrilled when I popped into a practice that treats quite a few veins. And one of the physicians had these like very stealthy looking glasses, magnifying glasses with the light. And I was like, wow, my gosh, I love those. How much were those? And what do you think she said? Amazon?
Yes, Amazon's a good place to get them.
Amazon. And they were about $15. Okay. So if anybody needs resources, please feel free to email me. I've got the Amazon connection. I know from just people that I visit and pop into their offices, I get the best finds from them. And to no avail, it's always Amazon. And you can set up a medical account under Amazon, and a lot of the supplies I get on there, surprisingly. I get 30 gauge half-inch needles. That I love 30 gauge half-inch needles, and I love the 32 gauge half-inch needles as well to perform sclerotherapy with. If you're doing, something different with ultrasound guided, that's a whole nother discussion. But as far as the cosmetic, sclerotherapy, the 30 gauge half-inch and the 32 gauge half-inch are my go-tos.
How about some technical tips for actually doing the procedures?
I like to bend my needle. I don't know what you like to do. When I'm training practitioners at the very start, I bend the needle for them and at about a 45-degree angle, and I just tell them, this is the way that I like to do it. And the reason why is because it will help glide that needle in very superficially. I find that practitioners, if they keep their needle straight, they'll dive deep in and they'll go right through that vein. They don't realize, most everybody that I've ever trained, the first thing that they'll say to me, I'm so great at doing blood draws. I am so great at starting IVs. And I say, that's great. Let's now remove that entire thought process, because this is the most delicate injection and you are barely putting the needle into the skin. We're talking, most times you can see the silver of the needle, and there are times that I'm only putting the bevel of the needle into these tiny little vessels. So, and there are a lot of times I'm guiding their hand too, so that they fully understand, like, wow, okay, that is a very superficial injection, almost like when you're doing, a TB test, because if I hear from anyone. If a patient is coming in or if a practitioner has had sclerotherapy done on themselves and they tell me that sclerotherapy is painful, I always say it's the technician. It's the person that was doing it. It should not be painful. This is such a delicate injection. We're utilizing needles that, you know, diabetics are injecting insulin with. This is a very, very tiny needle. So if this is a painful procedure for your patients, then you might be a little heavy-handed, you know. Um, and those 32 gauge half-inch needles will help a lot. And some of the patients experience a little sting from the medication itself. I get various different, feedback from patients. Some of them feel absolutely nothing, and some of them, feel the medication. But most of the times, they'll take 100. Let's say they'll take 100 sticks, and they'll say, "Oh, that wasn't too bad. That wasn't as bad as I thought it was."
So volume is key to these. How do you ask when you have a new trainee, how do you teach them in terms of how much volume they should be injecting?
Um, I mean, we per our product insert, we've got an exact volume. It's very difficult. It's like a point, 0.01. But what when you're in reality and you're with patients and you're injecting a vessel, I always talk to them about the blanching of the vessel. Um, if you see that, that's a great look. That's a great endpoint. If there is a wheal that occurs at the skin where that needle was initially inserted, I tell them to stop. Do not keep injecting. And the reason why is because you do not want to put too much of that medication in the subcutaneous tissue and potentially create an ulceration in that area. So sometimes you can get those wheals too when the vein is full of the medication, but in any case, stop when a wheal occurs. Blanching is fun. That's typically what gets people addicted to sclerotherapy is when they get to see the blanching happen and it's the ooh ah effect, and then the patient really gets into it and then they want to watch. So yeah.
You mentioned a little about the tactile feel of the injection because it's not just the volume, it's not just what it looks like, it's actually the haptics, what you're feeling during the injections. Can you mention a little bit how you teach that?
Yep. And I think that the feel, I just had somebody ask me the other day. She was like, "Do you aspirate on all of the reticular veins?" And I said, "Well, I've been doing this for so long. I can feel when I'm in a reticular vein. The needle glides very smoothly. Um, I also like to utilize a vein light when I'm injecting too with reticular veins. I think that helps a lot, and it does help you from having to aspirate necessarily because you can kind of see when you're in the vessel. Because some of these vessels are just they're weak and they're too small to do some aspiration. So a lot of times you can have that feel of when you're in the vessel where it's just very slick and gliding. With telangiectasias, when you initially get that needle in, I always tell people to have just the tiniest bit of pressure on their thumb on that plunger, because a lot of times when you're initially injecting or you're initially inserting your needle into a vessel, sometimes just that bevel alone, you're already in the vessel and you'll see that blanching occur. Sometimes I have people go in and out with their needle because sometimes as they're pulling out and they've got pressure on their plunger, as they're coming out of that vein, it will catch and you'll see the blanching occur. So there are several, ways that, again, it's one of those things, being in practice, being with somebody that can kind of guide you through the even where do I start? Where do I begin to even inject these two legs that are full of veins? Where do I begin? And, the thought process is, the highest point of reflux, we start treating first, proximal to distal. and go from there. So setting expectations with those patients is crucial too, because some of these women will say, all I want to do is wear a knee length skirt. So can you please just treat my, below the knee, and that's all I want. And I always have to bring them back to reality and say, I would love to do that. However, there's a lot of stuff going on in the thighs, and we need to address that first, because if we don't do that, we're not going to have the most effective treatment. The vessels, below the knee are going to return. You're going to be frustrated, and I don't want that to happen. I want you to be happy with the procedure, and I want to have us to have successful results.
So stepping back from the technique, if you, let's say, started to master some of the basics of the technique and you want to start your practice, how does the person who's just starting out start a cosmetic sclera practice?
Um, the training is crucial. And like I said, there we are here as a resource to help that process in terms of the didactic, the webinars. We've done several great webinars that are your basic, sclerotherapy 101, that discuss the anatomy and physiology, all the supplies that you potentially need in the practice. And you don't need a whole lot. The disposable part of this is very minimal, because you're talking about 3 cc syringes, your 30 gauge, 32 gauge needle, and your medication, alcohol swabs, alcohol and gloves. I mean, that's really it. And then compression, the verdict is still out whether or not, to wear compression or not to wear compression. I prefer for people to wear compression. It doesn't hurt. It's simple, and you know it's an easy thing to do. But so the resources first. Start with the didactic. Understand, for anybody who doesn't understand it, understand the process. Um, Knowing even like little things, after that underlying, stuff is treated, whether somebody has an ablation performed, wait several weeks before, addressing the cosmetic part. If there's a pregnant patient, we wait months for those hormones, to return to normal before injecting legs. So, um, but in terms of the business getting started, I think it's super important just to start with the didactic part and then move on to the hands-on, and trying to find somewhere to get that hands-on assistance is crucial, because practice is, I remember when I first started, back in 2002, and I went to a training at a facility and did the didactic, and they brought patients in and we were able to inject, and I might have injected maybe a handful of veins. And then they launch you out into the real world, and you're going, wait a second. I don't know if I'm really ready to, put the post out and bring everybody in for sclerotherapy and charge, $450 for a 30-minute session. I don't know if I can do that quite yet. So the friends and family is a great place to start with practice, but practice is crucial for this. I would say that's the most important part of sclerotherapy, that I've experienced over the years in training. We get calls, every single week from practitioners all across the country that have gone to trainings, and they come back and they just say, I'm just not quite confident in charging for this until I really know that I can inject and I can take care of these veins. So the practice is what's really important. So yes, getting your friends and family in and practicing right after you come back from training is really important.
So when you have your first couple of patients that you want to, you've gone to the friends and family, maybe some coworkers, so to
Oh
speak.
yes, yes. There you go. They'll give you their legs for sure. Everybody lines up, right? Don't they? Freebies. Yes.
So after you do that, how do you work out some of the financial aspects in terms of how much do you charge and do you do cash? Do you do insurances? Where do you start and how do you start?
Yeah. I don't even think I I don't know of which insurance is out there, the private payers are even offering a couple of sessions. There might be some still out there that offer some sclerotherapy sessions after they've had an ablation performed, and that's great. However, reality is that, and it's a good thing that this is the cash based portion of the business. I mean, why not? But the national average is about anywhere from 350 to 550. And then, of course, if you're in those highly, the New York City, Chicago, San Diego, LA, San Francisco, I've seen anywhere from 800 to $950 a session, which is nice. Would love to get that in Texas, but we don't. $350, 350 to about 450 here in Texas is pretty standard. But I always tell people, maybe make some calls in your area to determine what your actual pricing would be. And I think pricing per session is wise because if you start getting into the syringe, the ampule, all of that, it's too complicated for the patient, I think. Just keep it simple and charge per session. And I typically tell people keep it at 30 minutes to 45 minutes because it's a lot of sticks for a patient. And even though it's not bothering us because we're the ones sticking them, it's a lot to endure. So I usually tell people to stay, around that 30-minute, 45-minute time frame per patient and charge from there. And a lot of times, I would say most practices that I'm in across the country, they typically max out at 2 ampules of asclera, and each ampule of asclera has 2 mLs in it. So about 4 mLs. Our product insert maxes out the patient at 10 mLs. Obviously, physicians on here, y'all, you can do whatever you want with your patients. I'm just speaking to the product insert, but most practices that I see, they're not going beyond for cosmetic sclerotherapy. They're not going beyond the 2 ampules, and that the cost per box for 1% is around $118. So you guys can do the math in terms of what that out of pocket looks like. It's a great ROI, and making sure that you know your patients know that you are performing sclerotherapy, and if you're not, obviously sending them out to somebody who does. I mean, we want to do what's best for our patients and offering those referrals as well.
So part of that is preoperative and postoperative education of the patients in terms of what to expect, what not to do after they have postoperative care. Um, how do you set that up in terms of patient education? Because there are multiple aspects to that.
Yeah. We've got some really great resources that we actually just revamped our patient brochure. It's great. It's got a lot of Q&A in there that talks to the patient. So I always encourage practices prior to the patient even arriving to get a copy of one of our patient brochures that goes through those most commonly asked questions that patients ask before they even arrive so that they fully understand what they need to avoid even after treatment. Because there will be patients that will come in that think that, well, I'm going on a cruise next month and I want all my veins gone. And reality obviously has to be brought to their attention. So it's great to make sure that your front desk, when they're answering those calls too, and they're scheduling an appointment for sclerotherapy, that the front desk knows how to talk to the patient and ask them all the right questions. So I think it's really great to have a script prepared for front desk so that they understand how to communicate to a patient and ask all those right questions. Do you have any type of beach trip plan, going to the lake. Are you going to be in the sun? All of those questions. Are you going to be taking a long journey, to another country? Just the right questions to ask at the front desk is extremely important, because I know in my office, I'd have women coming in and I would find out, oh, my son's getting wet, getting married in 2 months, or we're going on a cruise in 2 weeks. How can we take care of all of this? And you're just going, oh no, I'm so sorry that you came in. But, expectations, super important to be set with these patients, and making sure that your office staff is educated in knowing how to communicate to the patients is extremely important. So that patient brochure is great for even the front desk to have. I think with any procedure, your front desk is, they're the key, right, to everything that's going on in your practice, and making sure they're communicating to the patients, not only with sclerotherapy, with other procedures. So having, I think, those patient brochures right at the front desk so that they can just pop that open and have that conversation with them before they even get scheduled. And I like for people to schedule consultations without treatment first, so that you fully understand what type of patient you have coming in, so that you understand how to set expectations for them. You can put together a treatment plan. Most patients ask, well, how many sessions am I going to have to have? So you have to set that stage as well. And we typically say, anywhere from 2 to 6, treatments, and you can space those out however long. But, asking questions is extremely important, especially with sclerotherapy, because you're dealing with a cosmetic patient. Cosmetic patients are so different from medical patients because their standards are much higher. They're paying out of pocket and they want to see results. And if they don't see results, they're going to go somewhere else quickly. So, photographs are extremely important. So, having a little area that's set up, not only for if you already treat, underlying disease, taking those pictures are very, very important. Taking pictures with each sclerotherapy session is something that I encourage practices to do, because patients will forget. There's a lot of veins, they will forget, and they will call and they will say, I don't think I got a result. I don't see any change. All you have to do is go to those photos, and obviously photos speak volumes to the patients. So, yeah, understanding that it's a cash, paying patient is really important, so that you understand how to take care of them even a little bit better than, some of the other insurance, or Medicare patients.
So while there's a lot of focus on ulcers after sclerotherapy, that's not what I find is the most common side effect.
No.
The pigmentation is the one that I find the patients have the most common. And how do you deal with that? How do you prepare the patients for that? And if you do have that, how do you treat it?
Yeah. Um, yeah, it's the main thing when I'm training people. I always tell them, and I'm the patients there, I always tell them, please try to come back, do your follow up in 2 to 3 weeks, especially if you're doing a lot of reticular work. Um, I see more staining, I see more trapped blood when a lot of reticulars have been treated. So I try to have the practitioners get in this mindset of, okay, patient comes back in 2 to 3 weeks, so that if there is any trapped blood, we can address it at that time. Because if you don't address that trapped blood in a timely manner, you're going to be dealing with staining, and that's a whole other issue. And that's another, if the patient even wants to proceed with trying to take care of it, which most women do, who wants brown stripes on their legs where they just got them treated, it takes months to have that staining resolved. Some of the med spas have lasers in their practices. So some people will utilize a KTP 532 to try to help break up the hemosiderin staining. I mean, people are trying to do whatever they can. I've spoken to some practitioners that will utilize microneedling with TCA, trichloroacetic acid, to help, lighten up some of the staining that has occurred. But most times the patients they'll have to wait it out. They'll wait out that staining. So really what's most important is getting that patient back. I would never inject a patient and not have them come back 3 months later. And I've seen it. And it happens. Some of these patients, they get busy, they cancel appointments, they don't come back. Um, that's why it's so important for front desk to fully understand too, how to follow up on these patients to make sure they come back, because nothing worse, and I've seen it. I've gone into some very well established vein practices, and I've seen some of the patients that have popped in and they have staining. And it's because the patient waited 6 months to come back in to get another round of sclerotherapy. And I've asked the question, well, what to the practitioner, what happened? And sometimes you just cannot control the uncontrollable. And some of the patients, a lot of times they're not compliant. And, I try to make sure patients fully understand this is something that could potentially happen to you. I don't want that to happen, because it will be months. And I show them photos. I think my favorite consult to date, and I still sing her praises. And actually, she was trained by Dr. Mark Meisner, and she worked in his clinic, and she trained her very, very well. She worked in that clinic for 15 years up in Washington. But she printed out all the potential complications that could happen after sclerotherapy. She printed it out, laminated it. She even printed out images of what's normal. So she had all the images laminated of normal and abnormal with sclerotherapy. And during her consult, she would show the patients. And then when they came back for treatment, she would remind them, if you see this trapped blood, this is what it looks like. Please call my office. Please come back in. If you see this happening, please call my office. Come back in. I love the visuals because patients get it when you show them the visuals. You can give them a consent form. Most people, including myself, don't really read thoroughly through those consent forms, because I just want to get in and out, and I'll just sign my life away, and don't pay attention. Most of those patients don't pay attention. And so you don't have a compliant patient a lot of times, because they walk off, they read the consent. Your office never gave them a copy of those post instructions. They head out to the lake the next day. They're in the sun. Staining occurs, or hyperpigmentation occurs, or whatever else occurs in the dirty lake. They never wear the compression, and then you see them weeks later. So visuals, I absolutely love that for patients. What's normal and what's abnormal. I think that's a great thing to incorporate into the practice when you're performing sclerotherapy.
How do you handle that patient who comes into the office, they went through the process and now they come in saying, I'm going to pay for one session. Can you take care of groin to ankle? I want everything back to a 20-year-old leg. How do you handle those? How do you handle those expectations? And often I think the patients are expecting a lot more than what's feasible in one session.
I know, it's so interesting. Some of these, we just came off of an aesthetic conference. I just got back from that, and it's so interesting that you'll have patients that will spend $600, for a quick Botox treatment, and then when it comes to the healthy legs in their veins, you know, $350, they want it all done, right? Like you stated, and they're 60 years old, they've got veins all over their legs, and they're like, I want this done today. $350. That's going to cover it, right, Doc? And so typically, and I've heard that a lot, and that's such a great, that's great to bring that up because I've heard it so much over the years, and I kind of giggle a little bit, and I just say I would love to take all of those veins away in one sitting. It's just I just can't do it. We're going to have to space this out, and if it's two legs, I typically tell them we're going to work on this thigh today. Then, we'll work on the other thigh. If you want to speed this up, you can come back later in the week and we can do the other thigh, and then we can just work our way down. This is a process. I'm not sure how your veins are going to respond to the medication. So we'll take a look at that in a couple of weeks when you come back. Let me see how you're progressing with sclerotherapy. And if I see that things are going in a really great direction pretty early on, then that'll give me a better indication as far as maybe how many more sessions you're going to probably have to have. But unfortunately, I cannot take care of all of this in one sitting and set the expectations right there. That's why the consultation is so important before you even start to treat, because you're going to set those expectations. This might take up to 6 sessions, and this is what the financial piece of this looks like. And I don't like to have financial discussions because I'm a softie, and have I know you out there. All of us have really big hearts in the medical field, and if we could, a lot of treatments we would probably do for free. However, we have businesses to run, we can't do that. So find somebody in the office that can be the bad guy and step in and have that financial conversation with them. If you can't do it, and say, yes, it's $350. It's a 30-minute session. We will take care of as many veins as we possibly can. The next session that you come in, it will be another $350. So each session, will cost that amount each time. And again, we'll take care of as many veins as I possibly can with each session.
So besides the technique, how do you set up the whole system? The front office, the billing people, the bad guy, um, the equipment. How do you set up the entire system? Because it really takes a whole system to make this work.
Yes. We provide virtual in services. I do that all the time. Or if I'm close by, I will go in and do an in service, just to have those conversations. Okay, front desk person, this is exactly what you say when you answer the phone, and prepare them for that. Making sure that all staff, get the same in service, and then I typically will do a separate in service for the medical team that's in the practice, because that's a lot more in depth. But we provide we provide in services for how to get up and running in the practice.
Practitioners also have to gain some confidence in the process, and that takes time, it takes patience. How do you develop that confidence with your own skill sets to start doing this routinely and build this into your practice?
Mhm. I think, when you're first starting, and this goes back to, your coworkers, your friends and family, when you first start injecting, taking a look at how well their results are before you actually start charging patients and offering it to patients, start there. Just so okay, I'm I feel pretty good that I'm going to get some pretty decent results here. I've got everybody in the office. I've treated a few veins there. I've treated, you know, my family. They look pretty good. All right, I think I'm jumping in the deep end. I'm going to do this. So I think that having the maybe a handful of people that are close by that you can keep an eye on, take a look at their results, and then go from there.
So one thing I wish I had done early on, that I didn't do in some of my practices, lessons learned from each case. How do you incorporate that so that you don't keep making the same mistakes? How do you incorporate that where you go back to each case and say what went well, what didn't go so well?
Hmm. And I typically get those calls, from the practitioners in the country saying, oh gosh, I'm not really sure. I get photographs often, of legs that have been injected saying, okay, I utilize the half percent and I'm not sure what I'm doing. I'm not really getting the results that I thought. And I ask questions, well, okay, did you do the initial consultation? Did you have that conversation about any underlying issue? Um, and then on top of that, I ask them, are you utilizing any vein imaging modality like a vein light? That is a game changer. If you're not utilizing something to visualize reticular veins and you're just sticking those superficial spider veins, you will have veins coming back. And I see, I get most of those calls are coming from practitioners. And when I ask that question, are you using any vein imaging device? They typically, well, most times they'll say no, they're not using that. And I'm like, aha, that's your issue. You've got to treat the feeding reticular veins before you even treat those spider veins. I know it's tempting. It is tempting because most people love to get the wow factor from injecting these spider veins. They're watching, on social media, some of these practitioners that post videos of, the blanching of the vessel, and it's exciting. But you can't do that all the time. You've got to inject the reticulars. And once you get the vein imaging device, you can get some of the ooh ah out of the vein imaging device when you're watching the sclerosant travel from the reticular veins. And then I always tell practitioners, go back and look at that area. We're not going to touch any of the spider veins that are sitting on top of that reticular. Let's go back and look at that area. And most times you go back, you look, and all those spider veins are bright red, they're irritated, they've been treated, and you didn't have to stick them 20 times to get every single little vessel. So that technique is crucial, and I see a lot of practitioners fail in sclerotherapy because they're not injecting reticulars. They're injecting only the spider veins.
Thank you and MetaPharm for putting this together. You really had some very concrete, practical, clinical situations with not only with the practitioner, but also the whole system of developing a sclerotherapy practice. I can't thank you enough for sharing your decades of experience and all across the country. There's so many different types of programs that you've helped set up. Thank you so much. This was really, really so helpful.
Oh my gosh, thank you. I appreciate the opportunity.